안녕하십니까. 일산 앞선 치과
Hello,
김용진 원장입니다.
I'm Dr. Kim Yong-jin of Ilsan Opson Dental Clinic. I have prepared online lecture about OneGuide with dental TV. I will not be able to tell you a lot of stuff, but I would like to give you some useful tips in using OneGuide clinically. I hope this becomes of great use for you. There will be 5 lectures from basic concept of OneGuide, OneCUS, OneMS, and accessories for troubleshooting. These will be addressed in my lectures. First, you need to have an understanding of digital guide surgery to use OneGuide. So in the first lecture, I'm going to talk about digital guide implant surgery. This is introduction. We talk about placing implant well. What does this mean? Well-placed implant. This is placing implant at the center of prosthesis. This is well-placed implant. How about this? I'm sure all men understand, but if you use public bathroom, and when you're using it, if there's someone very close, it will be very uncomfortable. It's the same with implants. If 2 implants are placed too close in the anterior area, you will not be able to restore papilla and get aesthetically bad results. This is the same for posterior region as well. You need to give patients self-cleansing space to allow good oral hygiene, or else there could be various implant-related issues. To give you more specifics, mal-positioned implant cause various problems. First, it's very unfavorable for biomechanic. They can lead to abutment fracture, implant tearing, or abutment screw fracture. A lot of machine-related complications can occur. As you can see in the anterior area, it's aesthetically very bad. Even if you have delivered the crown, if the patient cannot manage oral hygiene, there can be various maintenance-related issues. Malpositioned implant can cause various issues, and for dentists, it can be very problematic. As you can see, it's difficult to say this implant is aesthetic. It's the same in the posterior area. CAD-CAM abutment is recently used a lot, and people use custom abutment for prosthesis, but in terms of maintenance, as you can see, these problems can occur. A patient came in complaining of continuous inflammation and bleeding in gingiva around the implant. As you can see, that implant position is very bad. Mesiodistally, it's unfavorable. You can only see mesial distal position on panoramic image. Prosthesis was removed and decision was made to remake the prosthesis. The bridge on top, on upper left, the bridge was removed, and if you look here, you can see buccolingual position, which was not seen on panoramic image. Abutment screw access hole was too buccally inclined, so all 3 implants, the screw access hole was buccally inclined. Buccolingual position was very unfavorable. Implant was buccally inclined, so abutment had to be excessively extended towards the palatal. So abutment was removed. Take a look at this. The abutment emergence angle, it was excessively bent. Patient was not able to manage food impaction below there. Below the abutment, continuous gingival inflammation was caused. Because it was like this, the patient, whenever he or she brushed teeth, there was discomfort and bleeding. If we remake a crown and do prosthesis, will we be able to solve the issue? No. I talked with the patient again and decided to remove the implant. I removed all 3 implants placed, and because it was maxilla, I did not use EFR kit and used a fixture driver and taper kit and reversed it out. Good position. In terms of buccopalatal and mesiodistal, in order to place implant in a good position, drilling was done again towards the palatal. Osteotome was used to lift the sinus floor, and 3 implants were placed in good positions. As you can see, number 24, there was continuous peri-implantitis and there was buccal bone loss. In order to regenerate it, allograft and ostem builder was used and transmucosal GPR was done. Surgery was complete. Let's look at the panoramic image. Mesiodistally, the implant was placed very nicely after final prosthesis. Mesiodistally, implant was placed very well, so implant is positioned at the center of prosthesis. As you can see, emergence profile is very nice, and the patient has space to do self-cleansing and oral hygiene can be maintained easily. To compare, let's look at before removing prosthesis and implant. Implant has good mesiodistal position and buccolingual position and placement depths. This is the prosthesis. As you can see, cleaning space is there. As you can see in this case, implant placed wrong. Even if you use custom abutment, you cannot create a happy ending ultimately. The purpose of placing implant is not to make a crown, but to make a prosthesis where the patient can maintain it easily. If so, what can we do to minimize such mistake and place the implant well? In the initial phases, this is the first generation guide. You take impression and make model, and on top of it, you either do wax up or align the artificial teeth and create surgical stent. On top of it, make a vacuum-formed matrix using resin, and on align artificial teeth or wax up, drill hole for initial drilling. This is a very early guide. However, there's a problem. There's no dedicated surgical tool for it. And the guide hole itself, for initial drill, you use 1.5 lance drill or 2.2 twisted drill. However, the guide hole itself is thicker than initial drill. Therefore, if we use 2.2 twisted drill to get path and do initial drilling, we go in like this. Ideal path is like this, but if the patient cannot open very well, or if the surgeon does not have a lot of experience, the drill itself bends. Normally, the drill bends distally, and apex of the drill heads toward mesially and cause root damage in adjacent teeth. Mesiodistal and buccal palatally good position is where we should place the implant. Even if the position is good, implant angulation also needs to be considered. So in early stage guide, you cannot control angulation. In a severe case, it would damage roots of adjacent teeth. Even if you use the guide, the angulation can be wrong or you cause complication. Therefore, vacuum-forming matrix type of early surgical guide, you will not be able to control angulation, so it's not frequently used. ROI, compared with the effort, you get not much. The digital technology has developed, and digital trend is sweeping the dental society. The trend is changing. Like the changing length of swimming suit, digital is all the hype in dentistry. As mentioned earlier, analog type guide or guideless surgery, if you call that analog type, these days digital is all the trend. I'm an oral surgeon, and rather than changing fully digital, you can use some benefits from analog method like feeling the bone. But in order to routinely place the implant well, you also need to utilize the benefits of digital. That's why I want to use Digitalog, the middle between analog and digital. First digital experience was guide surgery. In my opinion, digital guide surgery, if you're a good surgeon, you would be able to do it better. And if for novices who fear doing surgery, I think you'd be able to do it more easily. However, digital guide surgery is not perfect solution. You need to master analog techniques. Digital guide surgery has become popular because of CBCT. Cone-beam CTA is widely used, and you can see teeth, bone, anatomic structure, mandibular canal, sinus, floor. You get accurate information of anatomical structure. And this has made guide surgery possible. Without CT, digital guide surgery might have been difficult. Another major contributor is CAD program. There are a lot of virtual planning software. Blue Sky Plan from Blue Sky Bio, or Implant Studio from 3Shape, ExoCAD's ExoCAD Plan. There are multiple software where you can plan implant placement. Based on the CT data gathered, you can plan implant placement. That's called CAD program. As you have seen, you may have good planning program and may have perfect implant placement plan, but if you don't have enough confidence in making it a reality, or if you don't have technique, if you don't have the necessary skills, implant can be placed in a way that was not desired.
Although the intention was to draw a unicorn, the result came out like this because lack of skills. In order to make the plan into a reality, you need something else. You need another tool to put the implant in the planned position, and that is the surgical guide.
3D printer has become more commercialized and the cost has become cheaper. Accuracy has increased, and using 3D printer, surgical stent can be easily and accurately printed out. Surgical guide has become very advanced. In other words, planning programs, virtual planning programs, CAD programs, CAM technology like 3D printing have developed and become more available to the public, and digital guided implant surgery has been adopted clinically. When you do guide surgery, there are many advantages. First is accuracy. If you have accurate plan, the planned position, you can use surgical template to make it into a reality in patient's mouth. In the past, I worked with 9th People's Hospital in Shanghai, China. I did research there. I used implant planning program. The patients were divided into 2 groups. In one group, implant was used and planning was done, and a very experienced surgeon opened flap and placed it. In another group, using the planned position using implant, a surgical guide was fabricated and the same doctor did placement. Using implant planning was done. In one group, brain guide surgery was done. In other words, based on the surgeon's experience. In another group, digital template was used for implant placement. Regardless of how experienced you are, digital guide surgical template showed higher accuracy.
Regardless of your expertise, the digital guide surgery was very useful.
From patient's perspective, it is less invasive, so it's comfortable. Post-surgery discomfort is minimized. Flapless surgery in most cases is possible, so it's very good for the patient. The surgery time is reduced and it becomes less invasive. Digital guide surgery can be applied not only to simple cases, but for more complex cases like a full mouth implant case.
I think it will be of great help regardless of whether you're a beginner or experienced.
In order to do digital guided surgery well, you need to understand the overall workflow of digital guided surgery. You need to understand it to maximize accuracy. Let's look at the workflow. This is the overall workflow. Let's take a look at closer look. As mentioned earlier, you need to take CT. This needs to be done accurately. Three-dimensional information of the bone width, mesiodistal distance, and anatomic structure distance. Next is surgical stent is put on top of adjacent teeth and on gingiva. So surface information is required. Surface scan or scanning data is required. If you have intraoral scanner like Trios, you can scan adjacent teeth and gingiva. However, if you don't have it, you can still do digital guide surgery. You can take impression and after that make model and do model scanning. By doing this, even if you don't have intraoral scanner, you can do a digital guided surgery. Even with model scanning, if you can take accurate impression, you can get accurate result. If you take CT and the data you get, the extension of actual data gained from CBCT is called DICOM, and 3D data with volume from surface scanning is called STL file. So you need to merge the two different files into one. We call merging when we merge the CT and surface scan data. And the teeth on CT and teeth on surface scan is superimposed. Merging is very important. If merging is done wrong, everything goes wrong. Implant placement planning is done on CT data, and a surgical stent is made on surface scan data. If this goes wrong, implant placement position becomes wrong. Merging is a very important first step. As I told you, by superimposing teeth, CT data and intraoral scan data, or surface data is merged. After you do model scanning or intraoral scanning, you design the tooth. Prosthesis design is done, and consider the relation with opposing tooth and design the ideal prosthesis and put the implant at the center of the prosthesis. This is top-down approach or restoration-driven implant placement. In the past, we would open flap and place implant where the bone was good, and then make a crown. If you use digital guided surgery, you would design ideal prosthesis and put implant at its center. Top-down approach is made possible. This is the case that I planned on CT. My area of interest is cut here. On the model, as you can see, on the right is model scan image, on the left is CT. I'm going to merge them. I'm going to superimpose the teeth and get accurate merging and model scanned image. I'm going to design ideal crown. Angle, size, and length can all be adjusted. The purpose of placing implant is to create ideal prosthesis. So you design ideal prosthesis first. And once this is confirmed on CBCT image, you put in the implant library. By doing this, you can see where the implant is and what depths at where area and where the screw access hole goes on the prosthesis. If you place implant like this, you need to choose whether this is going to be screw retained, or if the screw access hole goes labially, you can choose cement retained type. You can predict ahead. On CT, you can check whether there is bone defect or whether the buccal wall is thin or not. You can also adjust the implant angle or position. This is how planning is done. The plan position. If you like everything, Following this position, drilling and implant placement needs to be guided by surgical stent, and this stent is created here, like this. Implant position and angulation is confirmed, and after that, guide hole is created. To support this, additional elements are encompassed in surgical stent. The margin of surgical stent can be adjusted. This is how it's fabricated. This is digital guide surgery. Once surgical stent design is complete, you can extract STL file. And using this, by 3D printing, you can fabricate. At Austin's OneGuide Center, for guide, implant placement planning is done, and once you confirm it, surgical stent is designed, fabricated, and delivered. Once the fabricated surgical stent is delivered to the clinic, you can position it during surgery, and using OneGuide kit, you can do the drill. As mentioned earlier, digital is all the hype. So all implant companies have launched a dedicated digital guide implant surgery system for implant placement. Austin's digital guide surgery system is OneGuide. Each company has different digital guide template. Some have metal sleeve, some have offset, which I'm going to mention in the next lecture. Offset has fixed type and variable type, and offset length is all different. If you want to use OneGuide well, you need to understand its characteristics. Up until now, I talked about overall digital guide surgery and workflow rather than OneGuide. As I do OneGuide course, a lot of people asked me the following questions. The most frequently asked questions: what do I need to use for planning program? Is there Austin implant library? Can I place Austin implant using this? Currently, in order to use Austin OneGuide, you need to use Implant Studio from 3Shape. It's very fancy and expensive. It's a very great program. Austin Implant Library is included there. And OneGuide library to create OneGuide is also included. If you want to use a free program, currently Austin is developing and preparing to launch its own program. If you can get your hands on that, you can use it to make a Austin dedicated guide. What should I do to create my own guide? Up until now, rather than fabricating it yourself, it's better to request to Austin's Digital Center. You get a basic idea of the overall workflow, and you get a sense of what needs to be done to get an accurate guide. You need to do that first and then proceed with making your own guide. In order to do this, you need a planning program as well as a 3D printer. In order to have 3D printer and planning program at first, you may need to make some investment, but if you want to do it yourself, that could be the way. Third, if you do guided surgery, is it all flapless surgery? So I was going to talk about this on my 4th or 5th lecture, but not all surgery is flapless. A lot of people think that digital guide surgery is flapless surgery, but not necessarily. You can get more predictable result flapless, but you don't always do flapless surgery. This was the first lecture of digital guide surgery, and on the next lecture, I'm going to talk about OneGuide and benefits of OneGuide kit as well as OneGuide system. Thank you.